So let's start with the Parkinson drugs. Okay, so first of all, before starting with the Parkinson drugs, first of all we should understand what is Parkinson disease. Okay, so Parkinson disease is very easy to understand. Whenever the patient will be having the which neurotransmitter is involving over here? Dopamine. So usually what happens is dopamine neurotransmitter will be deficient in this kind of patient. Okay, and if the dopamine levels will be decreasing, okay, due to that what happens is tremor kind of situation will be seen in the patients, and usually these kind of tremors will be calling as pill rolling tremors. Pill rolling means if you are giving some kind of pill to these patients and their movement will be like this. Okay, so they are also called as pill rolling tremors. Okay, or counting the notes tremors and something like that. Whenever they will be counting the notes, they will be having the tremor in their hands. Okay, and these kind of tremors usually improves whenever they are starting some kind of purposeful movements. Okay, not purposeless, purposeful movements. For example, they are starting with some kind of work and these tremors will be resolved over there, right? So that was about the Parkinson. Now you are having two neurotransmitters balance, equilibrium inside your CNS, and I'm talking about which one? I'm talking about one side acetylcholine and one side dopamine. Okay, I told you about this balance in that class also, right? Anticholinergic class. So what happens is, if I'm talking about the acetylcholine and dopamine, so this is, let's say this is the dopamine and this is the acetylcholine. Okay, so usually physiologically, okay, there is a balance between, there is a equilibrium between these two neurotransmitters. Okay, now what happens in Parkinson disease? Dopamine level goes down. Let's say this was acetylcholine, sorry, this was dopamine, so dopamine level are going down. So as comparatively, what you can say, acetylcholine levels are high. So acetylcholine levels are high and dopamine levels are low. So you are having two things over there. So how you can improve the situation of this patient? Either you can increase the level of dopamine inside the CNS, so then there will be the equilibrium between this one, or one side you can decrease the level of acetylcholine. If you are decreasing the level of acetylcholine, which drug I am talking about? Anticholinergic. So that's why we can use anticholinergic drug over there. So they will be decreasing the level of acetylcholine. Next situation is you can decrease the level of acetylcholine and you can increase the level of dopamine. So you will be having combining effect. Decreasing the level of dopamine on one side, decreasing the level of acetylcholine on one side and increasing the level of acetylcholine on one side, other side. So that will be maintaining the equilibrium once again between this acetylcholine and dopamine. Understood? So this balance should be maintained. Okay, and our tactic for the treatment is to maintain the balance between these two neurotransmitters. Okay, now let's talk about that dopamine neurotransmission inside our CNS. So let's say this is the presynaptic neuron over here and this is the postsynaptic. Fine. And on the postsynaptic we are having some receptors. Okay, these are some of the receptors present over here, right? These are the receptors. Let's say these are the dopamine receptors present over here. Which receptor? Dopamine receptor. So these are the dopamine receptor. Inside the presynaptic cleft, we are having this one. What is this? Presynaptic vesicle. Presynaptic vesicle. So now usually what happens is there is a tyrosine. This is one of the amino acid which is the tyrosine. Tyrosine actually goes inside your presynaptic cleft or presynaptic neuron. Then this tyrosine converts into levodopa. Converts into what? Levodopa. So this tyrosine will be converting into levodopa. Now there is an enzyme by the help of which it converts. So this enzyme name is tyrosine hydroxylase. Okay, tyrosine hydroxylase. So with the help of this enzyme, tyrosine will be converting into levodopa. Then next what will be happening, levodopa will be converting into dopamine. Levodopa will be converting into dopamine. Again with the help of one enzyme. What is the name of this enzyme? Dopamine decarboxylase. Dopamine decarboxylase. Okay. So what is happening? Tyrosine is converting into levodopa with the help of tyrosine hydroxylase. Then levodopa is converting into dopamine with the help of dopamine decarboxylase. And further this dopamine will be going inside this presynaptic vesicle and they will be accumulating over there. Okay. Nothing difficult to understand because we have already talked about the cholinergic neurotransmitter, adrenergic neurotransmitter. This is the dopaminergic neurotransmission. Okay. Over there we talked about the acetylcholine in the cholinergic system, norepinephrine in the adrenergic system, and in the dopaminergic we are talking about the dopamine. Same things are happening, just about the difference between the neurotransmitters, right? So here we are using the dopamine. So this is the dopamine over here. Now what will be happening as the action potential will be coming? Influx of calcium ions. These are the calcium channel. These are voltage gated calcium channels. Opening of the voltage gated calcium channel will be happening. Calcium ions influx will be happening. Fusion of these two membranes will be happening. And due to that, what will be happening? Exocytosis of this dopamine. And now the dopamine will be accumulating inside this gap, synaptic gap, you can say, right? Okay. Now they are having the chance to bind to these dopaminergic receptors, right? Physiologically these things are happening. In Parkinson, what will be happening? Dopamine, you are lacking the dopamine. So if you are lacking the dopamine, you are lacking the dopamine in the synaptic gap also. If you are lacking the dopamine in the synaptic gap, they will not be able to stimulate these dopaminergic receptors. Okay, and that's why they are having what? Tremors kind of situation, right? Now how you can solve this situation over there? Okay, how you can solve this situation? So first thing is you can increase the level of dopamine over here. Okay, so you can increase the level of dopamine. So first thing you can do this kind of thing. Second thing is what? You can increase the release of this dopamine from this presynaptic neuron. Okay, so second thing you can solve over here. Okay, so you can increase this one, right? Now one more thing, I told you whenever I was talking about the norepinephrine in the adrenergic system, there were some seizures in the synaptic gap. What were these seizures? Yes, COMT, catechol-O-methyltransferase, catechol-orthomethyltransferase in the other words. While I was talking about the cholinergic system, I told you seizures are present over there as well in the synaptic gap, and they were breaking down the acetylcholine. What was those seizures? Acetylcholine esterase or anticholine esterase, right? Likewise, we are having seizures present over here as well. Okay, and what are the name of these seizures now? These are monoamine oxidase, MAO. Okay, and one more thing we are having over here, that is the COMT. Okay, MAO and COMT. What is the function of this MAO and COMT? Remember this sign over there, like a seizure. So they will be doing the breaking down. They will be breaking down this dopamine over there. Okay, they will be breaking down this dopamine over there. Now one more thing, if you want some detail over here, dopamine will be breaking down into 3,4-dihydroxy phenylacetic acid, 3,4-dihydroxy phenylacetic acid with the help of COMT, right? And this dopamine can be converted into 3-ortho-methyl-dopa, or you can say 3-O-methyl-dopa. Okay, 3-orthomethyl-dopa or 3-o-methyl-dopa. Okay, dopamine can be converted into 3,4-dihydroxyphenylacetic acid and 3-ortho-methyl-dopa. COMT will be converting dopamine into 3,4-dihydroxy and this one here, this is the MAO, and more specifically this is the MAO-B. This is MAO-B. Actually, monoamine oxidase is having two types. Monoamine oxidase is having two types. MAO is having two types. One is MAO-A, monoamine oxidase A, and one is monoamine oxidase B. Very easy to remember. A for all, B for brain. Okay, so MAO-B are present inside the CNS. MAO-A is present everywhere. For an example, it is present in the liver, it is present in the GIT, it can present in your brain, it can present anywhere inside your body, right? But MAO-B is actually predominating inside your CNS or brain, right? So if I'm going to talk about the MAO inside the CNS, I'm talking about the MAO-B. Okay, so here is the MAO-B. So what is happening over here? Dopamine is converting into 3,4-dihydroxyphenylacetic acid with the help of COMT, 3-orthomethyl-dopa with the help of MAO-B. Okay, so first thing I told you, we can increase the level of dopamine inside the CNS. We can increase the release of this dopamine. One more thing, so this was destroying this dopamine. So one more thing we can do over here, that we can stop this. We can stop this over here, that MAO-B will not be able to destroy dopamine into this one, and COMT will not be able to catalyze this dopamine into that product. Okay, so you can do that. If you are doing that, if you are inhibiting this MAO-B and COMT, you are increasing the level of dopamine. Yes or no? You can increase the level of dopamine, right? So that's how you can do that. One more thing, you can increase. So what happens is, dopamine, whenever more amount of dopamine is accumulating inside the synaptic gap, it can be reuptaken. It can be reuptake in the presynaptic neuron. So you can stop that as well. If you will be stopping that thing, dopamine will be accumulating inside the synaptic gap, and they will be having more chances to binding to these dopaminergic receptors, right? So these kind of things you can change in the Parkinson disease patient, right? So let's talk about the first situation over here, in which you can increase the level of dopamine. So I can say that first drug I can use over here is dopamine. First drug I can use over here is dopamine. But there is a problem while using this drug. Now what is the problem? Actually dopamine, look, I'm talking about the CNS. If I'm talking about the CNS, if the patient is taking this drug through the oral form, bioavailability is different thing, that 60% of the bioavailability will be present in this patient. Finally, this drug will be entering into the blood circulation. Now, with the help of blood circulation, where is the target site? Inside the CNS. So, it has to penetrate the blood-brain barrier. Now, the thing is, dopamine is not having the capability to penetrate the blood-brain barrier. So, can you give dopamine now? There is no use of giving dopamine to this patient. Okay, because it will be remaining in the blood circulation only, and it will not be able to show its effect in the CNS. So dopamine will be failing, right? Dopamine will be failing. So you can say dopamine is not lipid soluble, because that is made up of lipid. Blood-brain barrier is made up of lipid. Dopamine is not good lipid soluble, so you can't give this dopamine because it will not able to penetrate the blood-brain barrier. So dopamine will be failing in this situation. Okay, because it cannot cross, or it cannot penetrate the blood-brain barrier. Okay, now we came to know, if we cannot give dopamine, can we give levodopa? Yes. Because finally it can be converting into dopamine, and it will be increasing the level of dopamine inside the CNS. Okay, and then they came to know that we can give levodopa also. So let's talk about the levodopa now. Okay, so now we are not talking about the dopamine because it will not be effective. So let's rub that. So remember, as dopamine is not lipophilic, it cannot cross the blood-brain barrier. Okay, so we are not using that. So what we can use now? Levodopa. Okay, so we know that how we can use levodopa. Levodopa can be converted into dopamine. Okay, so we can send this precursor because levodopa can cross blood-brain barrier because it is lipophilic structure. Okay, now what will be happening? Let's say this is the blood circulation. This is what? This is blood circulation. This is some kind of blood vessel. Okay, and you gave which drug? You gave over here this one, that is the levodopa. Levodopa. Okay, now levodopa is also having the problem. What problem? I told you levodopa can be converted into dopamine inside the CNS, inside this presynaptic neuron by the help of dopamine decarboxylase. In the periphery also it can convert into dopamine. In the periphery also it can convert into dopamine by the help of which enzyme? Dopamine decarboxylase. So I am writing dopamine decarboxylase, DDC. Okay, dopamine decarboxylase. Now the thing is, as if you are giving levodopa, okay, that levodopa can penetrate the blood-brain barrier and it can go inside over here. Okay, so it will be replacing this one, right? As it was lacking in the patient, as it was lacking in our CNS patient, in our Parkinson disease patient. But what is happening? Levodopa, as you are giving levodopa will be converting into dopamine. Okay, so mostly 95% of levodopa will be converting into dopamine. And again, what is the problem? Dopamine cannot cross blood-brain barrier. So most of the levodopa is having no use. So only 5% of levodopa will be able to go to the presynaptic neuron. Okay, so again there is a restriction for giving the levodopa. Then we came to know if somehow we can inhibit this dopamine decarboxylase. If somehow we can inhibit this dopamine decarboxylase, we can solve this problem. Because if you will be inhibiting this enzyme, levodopa will not be able to convert into dopamine. So most of the levodopa you will be available. Okay, so most of the levodopa can penetrate the blood-brain barrier. Okay, so which kind of drug we are using over there then? So levodopa, we are combining this drug with carbidopa. Okay, so we usually combine this drug carbidopa. What is the function of this carbidopa? Carbidopa, actually this is inhibiting your dopamine decarboxylase. Dopamine decarboxylase. Understood why we are combining the levodopa with carbidopa? This combination over here is the most effective combination. This is most effective in Parkinson. This combination is most effective in Parkinson disease. So this is the most effective drug, you can say, the drug combination in the Parkinson disease, right? Okay, now one more problem came now. So first problem, we were talking about the dopamine. You cannot give dopamine, cannot cross blood-brain barrier. Second thing, levodopa you can give, but most of the levodopa in the periphery, they can be converting into dopamine. Again, problem persists. Then we came to know we can combine levodopa with carbidopa. Okay, so the problem is dopamine decarboxylase is present in the periphery. Dopamine decarboxylase is present inside the CNS also. Okay, so if you are inhibiting this dopamine decarboxylase, you are inhibiting this one also. Yes, you are inhibiting this one also. So now what will be happening? You send this levodopa over here, but as you are blocking over here, will this levodopa will be converting into dopamine? No, again the problem comes, because levodopa, you do not want levodopa actually. Eventually you want what? Dopamine inside your CNS. Okay, dopamine inside your CNS. So what will be happening due to that? If you are giving more doses of anti-Parkinson drug, okay, if you are giving more doses of anti-Parkinson drugs, then it can increase the level of dopamine. Okay, so we need to give more amount of levodopa so that some of it can be converting into dopamine eventually. Okay, because most of the levodopa will not be able to convert into dopamine, so we need to give more doses of levodopa so that if we are giving over here, let's say hypothetically I am saying 100 molecules of levodopa, okay, at least 50 or 60 they will be able to convert into dopamine. Okay, so we need to give high doses of that one. Okay, then the thing is less level of dopamine. If we are talking about less level of dopamine inside the CNS, we are calling this problem as Parkinson disease. Parkinson disease. Now if there are more level of dopamine, that is also the problem. More level of dopamine inside the CNS, we are calling that as psychosis. Okay, we are calling that as psychosis. For solving this problem, we are using anti-Parkinson drug, right? We are using anti-Parkinson drugs, and for solving this problem, we are using antipsychotics. Okay, so what can I say over here? If I'm using anti-Parkinson drug, they are increasing the level of dopamine, so they can cause what? Psychosis. So what can be the side effect for while using the anti-Parkinson drug? Anti-Parkinson drug, if you are using them in more amount or overdose, you can say that you will be increasing the level of dopamine, and that will cause psychosis in the patient, and vice versa. Because if you are using antipsychotics, your goal is decreasing the dopamine levels. So if you are using more doses of antipsychotics, you can cause Parkinson. Okay, so what can I say over here? Anti-Parkinson drugs, they can cause psychosis, and antipsychotic drugs, they can cause Parkinsonism. Understood? Okay, so that is the thing over here. Fine. So overall, what can I say? In the first method of treating the Parkinson, we can use levodopa with carbidopa. So this is the combination over here which we can use. Okay, so levodopa with carbidopa, most effective treatment in the Parkinsonism. Okay, now let's talk about the second thing over here. And what is the second thing? Second thing is that you can increase this exocytosis, and one more thing, with the same drug you can decrease the uptake of this dopamine. Okay, decrease the uptake of this. So two things will be happening over here. First thing, exocytosis will not be able to happen. Second thing, uptake of this dopamine will not be able to happen. And due to this combining effect, can we use this drug in this case? Yes, we can use this drug, and the name of this drug is Amantadine. Name of the drug is Amantadine. Okay, Amantadine. Question comes, which of the following drug, 4 options will be coming in the options, which of the following drugs, which of the following antiviral drug can be used in Parkinson disease? Answer is Amantadine, because Amantadine you can use in the influenza virus also. Amantadine is the drug which you can use in influenza virus also, and you can use the drug in the Parkinson disease also. Okay, so remember they are having two effects. So one is the Parkinson, and one is they can be used in influenza virus also. Can be used in influenza virus. Okay, so can be considered as antiviral drug. Fine. Okay. Then next category. So second one was this one, that we are decreasing the uptake and we are increasing the exocytosis process over here. Third thing which we can do, we can inhibit this. Yeah, so we can inhibit this MAO-B. We can inhibit this MAO-B, and fourth one we can inhibit this COMT, right? So let's talk about this MAO-B now. So MAO-B inhibitors, so if you talk about MAO-B inhibitors, we know how they will be working. They will be working by inhibiting the MAO, and that dopamine will not be able to convert now, so dopamine level will be increasing. What drugs we are using over here is salicylic, okay, and rasagiline. Okay, salicylic and rasagiline, they are the MAO-B inhibitors. Salicylic and rasagiline. Okay, they are the drugs which we are using in the category of MAO-B inhibitors. Okay, Fine. Then one more category. What is that? COMT inhibitor. So COMT inhibitor. So this was the third one. Okay. Fourth one is COMT inhibitors. Okay. COMT inhibitors. That is entacapone, okay, and tolcapone. Entacapone and tolcapone, okay, entacapone and tolcapone. Now more preferable you can say over here is entacapone. This is the more preferable. This is more preferable because tolcapone is having the capability to do hepatotoxicity or liver toxicity as a side effect. Okay, that's why we usually avoid this tolcapone. Okay, so entacapone is more preferable. Okay, so they are ending with what? They are ending with capone. Okay, how you can remember they are causing the hepatotoxicity or liver toxicity? So T for TO for toxic, L for liver. Okay, so toxic to liver. Fine. So hepatotoxicity they are causing a side effect. One more thing, but tolcapone is very effective if you talk about as compared to entacapone. However, entacapone is preferable, but tolcapone is effective as compared to entacapone. How? Because I told you about the COMT. Okay, COMT I told you over here that they were acting as seizers. So COMT they will be converting this dopamine into this 3,4-dihydroxy phenylacetic acid. One more thing, in the before the blood-brain barrier. Okay, if this is the blood-brain barrier over here, if this was the blood-brain barrier over here, this is the blood circulation peripheral and this is the central thing. Okay, here also you are having what? Levodopa, and here also you are having what? Dopamine. Okay, now with the help of COMT, this dopamine can convert into what? That thing, 3,4-dihydroxy phenylacetic acid. 3,4-dihydroxy phenylacetic acid. So this tolcapone, which can cause liver toxicity, this tolcapone can inhibit this COMT in the periphery, in the peripheral blood circulation, and the same tolcapone can inhibit this central COMT. So they are having two effects. However, we are not using tolcapone. We are using what? Entacapone. Entacapone is inhibiting this COMT only. So entacapone is inhibiting this is inhibiting your central COMT only. Whereas tolcapone can inhibit your central as well as peripheral COMT. Okay, but tolcapone can cause liver toxicity or hepatotoxicity. Fine. Okay, so we have talked about the 1, 2, 3, 4 categories. Okay, fifth category we can also use. Fifth category is if you can stimulate these dopamine receptors anyhow. If you can stimulate these dopamine receptors, can you solve the problem in Parkinson? Yes, you can, because if the dopamine receptor will be stimulated, then even less dopamine can give you the effect of antiparkinsonism, right? So fifth one we can say that we can use those dopamine agonists. We can use the dopamine agonist or dopamine receptor agonist. So let's talk about, shall I rub this one? So let's talk about the dopamine receptor agonist. Okay, in the dopamine receptor agonist, we are talking about two categories. Okay, dopamine receptor agonist, we are talking about two categories. In these categories, one is ergot, okay, and one is non-ergot. Ergot and non-ergot, right? Now, usually ergot is having more side effect as compared to non-ergot. Okay. So what is the drug over here in the ergot? So in the ergot, this is the bromocrypt.